Right, thank you very much, Vanessa. I'm really fascinated by this panel and looking forward to what we're going to hear. As Vanessa says, I've been involved in pushing public health policy as a lawyer for well over 40 years, and the reason for that, when we start looking at areas of health, is that it's up to doctors and scientists to figure out why people are getting ill, why people are dying prematurely. But once we have answers to those questions, it becomes a social, legal, political question of, so what are you going to do about it? And historically, there's an awful lot we've done about it. So if we consider where life expectancy is now compared to what it was, say, the time my grandparents were born in the late 1800s, human life expectancy is more than doubled. It's like everybody alive has been given an additional life. It's extraordinary. And so much of that is just basic public health measures. And, collectively, we've got something like 200 billion additional years of human life among people currently on the planet as a result of these advances in life expectancy. And again, something like 85% of that go down to basic public health things. Where are we going to get more billions of years of collective human life? Well, but continue to do the same sort of things. What are the health measures that we can enact? What are the things that we can do that leads to a healthier population? And this constantly gets into battles about how is policy formed? And there's a wonderful quote that's attributed to Bismarck, but I don't think Bismarck actually said it, that a man who likes sausage and respects the law should never be subjected to seeing either of them being made. It is a challenging thing, and there's this tendency to think that it's this constant battle between science and politics. You have these great public health people saying, here's exactly what we need to do, and you've got politicians who sort of mess it up by saying, but here's what we want to do. And we're here to discuss why that science policy divide is not necessarily a good way to look at things. There's an interaction going on here. I've seen it all my life, and I'm now dealing with people who've studied it and have a far better understanding of what's going on. And it's important as we look at where do we go? What more can we accomplish? Because there's no sense going into a battle to try to promote health and not be well armed, not know what it is we can do that's going to make a difference. So I think we have to look at what can be accomplished, but also know that there's a limit as to what we can accomplish, because market forces and consumer choices being what they are, people will often just ignore us. And that gets into some more of what we're going to talk about of what happens when the public loses respect for those authorities. What happens if they feel they've got a better idea than some of the authorities? What happens if they're right? So it's a fascinating area. It has huge ramifications for where we're going to be going with human life expectancy and quality of life. And to start off, we've got fantastic speakers. And to start with, Sam's going to be speaking first. And Sam has a resume that is very long, very distinguished, currently with the University of Michigan. I could highlight various things, but it's also very easy to just Google him. The things that I think are most relevant for what we're looking at is he was general counsel, for you non-lawyers, that means head lawyer, for the Office of Management and Budget. The Office of Management and Budget is basically the policy side of the White House. What's the president trying to do? What's the administration trying to do? How do you cause this to happen? So you can look at the president as being the brain, and this office as being like the spinal cord, and somebody like Sam as being the neurons. It's trying to make sure everything works and the messages get out to where it's supposed to be. And then he moved on from that. This is under the previous administration. I need to warn everybody. So there's no clown car involved in this meeting. And then moved to be the general counsel, again, chief lawyer for the Department of Health and Human Services. And as everyone should know, that is a huge department with tremendous impact, not just in the United States, but elsewhere. So very involved in the development of policy, advising on policy, defending policy, implementing policy. And he's here to tell us how we do it. Sam.
Thank you very much. I really appreciate the introduction and really appreciate the chance to come here. I have for many years been hoping to get an invitation to this university and this law school. Ravi Malhotra, who's on the faculty here, was my student many, many years ago, and someone who I have learned a lot from through the years. And I was just super excited when I left my job in DC at the end of the previous administration, returned to the academy to have the chance to talk here. This topic is, I think, an incredibly important topic. It becomes more important by the moment. I will definitely draw on some of the experiences that I had as the chief lawyer for the Department of Health and Human Services and for the Office of Management and Budget during the Biden administration, particularly as we worked through the darkest days or some of the darkest days of the COVID pandemic, and did various things to emerge from it with some degree of success. And I have found myself in this very interesting position, which I think is true of a lot of lawyers. So for the 4 years that I was working in the Biden administration, and particularly the 2.5 years I was at the Department of Health and Human Services, I was in this sort of science politics divide, often thought of as the politics person. I was the person who was talking to the scientists, who often looked at my name and didn't see the initials after my name that they thought of as being particularly important and serious, like PhD or MD, and saying, there are things you need to be considering here that are external to your disciplines. And then since I have left, and we have seen this incredible attack within the United States on the institution of science and on independent scientific decision-making, I have found myself very much in the position of being the defender or a defender of these institutions. I think these are institutions that are incredibly important, but also incredibly fraught in terms of their relationship with science and democracy, and it is necessary to keep both of those points in mind. So I start here with the proposition that in much of the United States' public discourse, and I'm interested to hear the degree to which it's replicated in Canada as well, there is this taken for granted distinction between science and politics. People from various points of view, whether they prioritize science or prioritize politics, believe there is a clear divide. And so when we think about President Trump, whether in his first administration or now, we have many people who oppose President Trump saying the problem is he's not following the science. And that was true before COVID. That was certainly true in COVID. And how can you question when someone says we need to inject bleach or shine lights inside of our mouths and thinks that's a serious response to COVID? Well, obviously, one answer is we have science about that. But there was a much broader critique from many folks of the first Trump administration, and now that the problem with the policy was not following the science. On the other hand, we had many folks from the Trump side of the world, and we're really seeing the return of this now, saying the problem was that science was not staying within its lane, that science was then scientific institutions and people with scientific training were instead acting in a way that was displacing political decision-making. And the current Secretary of Health and Human Services in the second Trump administration, Robert F. Kennedy Jr., is the embodiment of the idea that science has gotten too big for its britches. We need a populist response. So we see anti-vaccination. We see an idea that all of anti-pharmaceuticals in a very significant way, anti-scientific research. We see a massive attack on the institutions of science, whether that's cutting off research funding, whether that is redirecting research away from the things that scientists believe are appropriate to research, are appropriate fonts of research, are likely to bear fruit, or whether we see that in terms of replacing people with scientific training with other people in making decisions. And so we see a divide, a perceived divide between science and politics, and we see sort of liberal elite science on one side, and we see conservative populism on the other. And I would say within the United States, there are very few people who don't fall on one side of that divide. And what I want to say, I mean, I have very clear sympathies here. You know, I was an appointed official appointed by President Biden. You know, I very strongly believe in the institutions that are being torn down by President Trump and Secretary Kennedy right now. I have clear allegiances here. But I want to say that the idea that there is an inherent divide between science and politics is false. The question isn't science or politics. When we're administering laws and public policies, particularly in the public health context, but not exclusively, and we can talk more about that, science and politics are always very deeply intertwined. When we're designing a system of regulation that implicates scientific questions, policymakers are going to be deciding whether, when, and how to defer or delegate to scientific decision makers, and that's inherently a political decision. And the question is not, do we have science or do we have politics? The question is, how do we best ensure that scientific decision makers act through institutional structures and legal rules that promote democratically endorsed ends and means, recognizing that democracy itself, unfortunately, is increasingly a highly contested concept that has many different dimensions. So there are different ways of ensuring democratic accountability and responsiveness of scientific decision makers. Sometimes it's through very prescriptive rules, but other times the people acting through democratically elected representatives may feel, and appropriately feel, that the best way to respond to evolving concerns, to significant problems where our understanding is changing very quickly, is to give very broad delegation to decision makers with scientific training. So what I want to do in the few minutes that I have is talk about three things. One, I want to elaborate more, and I'll probably spend most of my time elaborating more on the point that it's not a decision between science and politics. There's always science and there's always politics. How we deal with science within the government is always and inherently political. And I'll give a few examples of that from the public health context. Then I want to make a democratic argument for deference or delegation significantly to scientific decision makers. I will do it from the United States context because that's the context I know, but I'm very interested to engage about how that's similar to or different from the way things are here or elsewhere in the world. And then I want to talk about some of the democratic dangers of deference or delegation to decision makers with scientific training, and how some of those democratic dangers we have walked into in the past in ways that have created our problem today, and how we should think about getting past that. Okay, so the biggest point I want to make is that deference or delegation to science in the regulatory state is inherently political. In part, that's because in the regulatory state is really an important qualifier here. We're talking not just about people coming up with ideas and testing ideas in the abstract. We're talking about delegating coercive power of the government to people. That's always going to be a political decision. Whether those people are people with scientific training or not, whether they're acting according to understandings that they develop through scientific communities or not, that is always going to be a political decision. But that's not all of the political nature of scientific decision-making within the regulatory state. Science, we often say, trust the science, follow the science, right? This is, I don't know whether in Canada you have these are my people, and so I really shouldn't say this, but, like American liberals love to put up these signs on their front yards. In this house, we believe in science. Okay, like what does that even mean? I have one too, but we don't put it out front. But I have the magnet on my And what does that even mean? I find it, but science is not a thing. Science is multiple things. It's multiple different communities that come together through common training, through common experiences, through common ways of looking at the world, through common backgrounds and shared norms, and that apply those backgrounds and norms and ideas and knowledge to particular problems. And there are multiple scientific communities that have different perspectives and different ways of looking at problems. And in public health, we see this very strongly, right? So if you think about how you identify and respond to public health problems, you have to take account of all sorts of different scientific disciplines that might not see everything the same way: epidemiology, biology, chemistry, medicine, psychology, mass communications. Public health agencies have to integrate these different perspectives and make decisions that necessarily at different times favor different scientific perspectives over the others. In the United States, when the Food and Drug Administration decides whether to approve a new tobacco product, for example, something I was involved in a lot with various vaping products at the Department of Health and Human Services, well, what do? They commission reviews from different disciplines, from chemists, from toxicologists, from pharmacists, from epidemiologists, from statisticians, from behavioral scientists. And when these folks disagree, which they do sometimes, they have to have a process for resolving the disagreement. If you look, the Trump administration has not destroyed this yet. If you look at the Federal Food and Drug Administration in the United States, there is a very specific scientific dispute resolution policy that talks about how we deal with these different disciplines. And even if all scientists from all relevant disciplines did agree on a given decision, there are very few decisions made by public health agencies that you could say are purely scientific in the sense that they're just about ideas. Think about the COVID pandemic and how we responded to the COVID pandemic. Various agencies at various levels of government, listening to scientific advisors, imposed various different kinds of restrictions at different times. When deciding whether to close schools, well, scientists can tell us how likely it is that having schools open will spread COVID to other people at the schools and to their families. Obviously, people will get stuff wrong in the context of a fast-moving pandemic, but they can give their best estimate as to that. What they can't do is tell us how to weigh the trade-off between spread, between potential learning loss, between economics, right? We might have experts in each of these fields who can advise us as to what are likely outcomes of various courses of action. It's a political choice how to weigh them. In the United States, the federal executive branch imposed an eviction moratorium during various points of the COVID pandemic. This was justified as a way of preventing the spread of COVID, with the idea that people who are evicted from their homes will ultimately end up in homeless shelters and other congregate settings, which are very likely areas of spread. And if we have high rates of COVID infection in a particular place, we're likely to spread the pandemic further if we allow evictions. Now, that's a perfectly plausible understanding of why we should bar evictions during a pandemic, particularly in places where it's bad. However, there's also a trade-off, an economic trade-off, with the property interests of the landlords. Both the Trump administration and later the Biden administration weighed that in favor of avoiding the spread of the disease. The US Supreme Court came in and said, no, 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 no. There is no way that the legislature, that Congress authorized public health officials to cast this trade-off in that direction, and invalidated the eviction moratorium. Now, who's right? Is the Supreme Court disregarding the science? I would say, no, they're not disregarding the science. They're saying it's outweighed by a different consideration. And that's true, and whether you agree or disagree, I was working in the Biden administration on the eviction moratorium. I defended the eviction moratorium in court, and later defended the eviction moratorium against property rights claims by the landlords. I have a particular view, but I can't say the Supreme Court, I think they were wrong in their decision. I can't say they got the science wrong. What they got wrong was the law and the politics. And so that is a common issue within public health. I've talked a little about the FDA, Food and Drug Administration, when it approves tobacco products. Well, think about when it approves drugs. So within the United States, the rule is that Food and Drug Administration has to approve all new drugs. It can approve new drugs only when they're safe and effective. What does safe and effective mean? Well, safe and effective means something different depending on what the benefit is of the drug. So a safe and effective drug to address something that is a very serious problem, well, we might accept a little less safety in the interest of more benefit. It's a cost-benefit analysis. We might accept a little less certainty of effectiveness if there is a serious disease that has no other treatment. Again, it's a cost-benefit analysis. This is not a purely scientific question, and that analysis can work its way into questions that seem like they're much more purely scientific. So usually what the Food and Drug Administration requires for approval of a drug is at least 2 double-blind, randomized controlled studies to show safety and effectiveness. Well, what if we have a very rare condition? It may be impossible to have those kinds of studies. And so what FDA will say is, if we have a rare condition, there's an unmet need to address that condition, we will loosen our requirement for 2 randomized controlled studies. We might accept studies that don't focus on the ultimate endpoint of actually curing or providing improvement in a condition, but have a proxy endpoint because that's all we can see. Well, that might be good enough. Now, is that a scientific decision? In a way, yes, but it's motivated by a policy judgment that it's better to take certain risks in terms of safety or effectiveness where the alternative is to have no treatment at all. And we see very significant disputes within the Food and Drug Administration among the scientists about how to apply these rules. When those disputes are resolved, they're resolved by someone who is a scientist, who has very strong scientific credentials. They're resolved in a way that is justified publicly as being a scientific decision. But you can't say that the science is on one side and not the other when all these equally credentialed scientists are disagreeing. Okay, one more FDA example, then one research example, and then I will talk about kind of the democracy, both positive and negative democracy issues here. So other FDA example, I've talked a little bit about tobacco products. So we adopted in the United States a law, the Tobacco Control Act, during the Obama administration, which gives the Food and Drug Administration the power to authorize new tobacco products, including vaping products. The FDA has approved tobacco-flavored vaping products on the grounds that they are likely to provide a pathway for cessation of combustible cigarette smoking, which is very dangerous, and vaping is less dangerous, although still dangerous, than combustible cigarette smoking. And tobacco-flavored vaping products are unlikely to lead new smokers to initiate. People aren't likely to start using tobacco or using nicotine with tobacco-flavored vaping products. The Food and Drug Administration has made a different determination with regard to fruit flavors and candy flavors for vaping. They've found, based on the evidence in front of them, that combustible cigarette smokers are unlikely to need to have fruit or candy flavors to switch. They have tobacco flavors. There are fruit and candy flavored combustible cigarettes are illegal in the United States already. And so it's not like they need fruit or candy flavors to entice them away from combustibles. And fruit and candy flavored vapes, when they were allowed in the United States, were a massive way of enticing teenagers and even younger children to start using nicotine. So FDA said, we're banning those. What about menthol flavors? In the United States, menthol flavored cigarettes, combustible cigarettes, are legal at the federal level and in most states. Some states have banned them. So, and about a third of combustible cigarette smokers in the United States smoke menthol cigarettes. It's a very big deal. It would be a very big deal to get them to switch to vaping. If menthol vapes would encourage them to switch without enticing children to start, that would be a very good thing for the public health. The first time the FDA considered a menthol vape product, it basically decided that the staff initially, the scientific staff initially decided, yeah, menthol is different than other flavors. You're more likely to get switching from combustibles, and you're less likely to get children to start. And so we think this is probably something we should approve. The head of the Center for Tobacco Products at FDA disagreed and said, no, 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 no. I think the issue is flavors for kids, and having menthol flavored vapes will entice kids to start. Maybe not quite as much as fruit or candy flavors, but a lot. And there's not good enough evidence that combustible cigarette smokers, including combustible menthol smokers, need menthol vapes to switch. So I'm not going to approve the menthol vape. This got litigated before a federal court. And what's really interesting is the federal court said, well, ultimately, the FDA decided the science required rejecting the menthol vape product. There was a discussion among the scientists, and they ultimately all agreed that the science meant this menthol vape shouldn't be approved. And I would just say, I mean, great, like we defended that. I was one of the lawyers who defended that. There was science on all sides. It was really a question of how you weigh various risks, which is inherently a political question. Okay, last issue. And then I'm going to talk about some of the democratic issues. So, oh, and by the way, FDA later approved a different menthol vaping product. So we now have a menthol vaping product on the market legally in the United States. Which I happen to think is a good thing. To me, that balances the risks in a better way than prohibiting them altogether. So let me talk about a research example, so-called gain-of-function research. And nobody really knows what that term means, but the basic idea is you engage in scientific research with various kinds of infectious pathogens in ways that either increase their infectiousness or increase the harm they'll do if they become infectious. And there are good scientific reasons why you might want to engage in this. And if you have a broad enough view of gain-of-function research, almost any kind of research is gain-of-function research. But, what people are really focused on is something like you have a coronavirus that you make a lot more infectious in the lab. And there are reasons why you might want to do that, because that allows you to test, how it might transmit various kinds of treatments. On the other hand, it's very risky because, someone in the lab could accidentally get it and then spread it to the world. Obviously, in the context of COVID, this has become highly politicized. as the so-called lab leak hypothesis has become highly politicized. I am one who happens to think we will never know the answer about how COVID emerged as a pandemic. I do not think we can rule out the idea that COVID leaked from a lab, given the practices of the Wuhan Institute of Virology, which were very loose. On the other hand, there's lots of reason to think that this virus came, and in its form, came from somewhere else. I don't think we're going to know the answer. But the politics of gain-of-function research have become incredibly fraught. And one way of thinking about this, and the way many people in the scientific community think about this, not all, is this is politics against science again. Many scientists respond to regulation of gain-of-function research and have since the first regulations in the United States in the Obama administration have responded as if any regulation is anti-science. And so I'll just read you a quote from 2014. In 2014, there were many folks pushing for a new regulatory regime for gain-of-function research. And one leading virologist in the United States said, you cannot tell scientists what to work on because you never know where the next good result is coming from. Another leading scientist in 2014 said, this is the new McCarthyism, telling scientists how to practice science. Now, whatever your sympathies on the gain-of-function issue, I think it should be clear that the scientists can tell us what are the risks and benefits of gain-of-function research, how to define gain-of-function research, what are the different kinds of research that might come within different definitions. What they can't do is, for themselves, weigh the risks and benefits. That's a political question and requires democratic decision-making. Okay, so all that might sound like I'm being kind of anti-science here, but I'm not. Because this moves to the next point that I want to make. There are lots of reasons why, as a democratic matter, we want to, and we have in the United States, delegated democratically decisions to various scientific decision makers, right? Why do we want to do that? Well, it's the same reason we want to have delegation to administrative agencies generally at some level, right? These are complex decisions involving fast changing information. These are not the kinds of decisions that folks within legislatures, and particularly the United States legislature with our array of veto points, can make. If we want to be able to respond to significant problems, we need to delegate to administrative decision makers. We need to delegate to decision makers with expertise. And in the area of health in particular, we need to delegate to people who have scientific and medical expertise. So that's part of the answer. And we have seen through the years in the United States, legislatures have delegated these kinds of decisions to scientific decision makers. It is the FDA that has delegated the power to decide what is safe and effective in terms of a drug. And we have seen the courts enforce that delegation. So when in the early 2000s, first the George W. Bush administration and then the Barack Obama administration imposed political overrides on FDA decisions about approving over-the-counter contraception, over-the-counter emergency contraception. Courts stepped in and said, no, 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 no. You are introducing into the process a political component favoring essentially, religious conservatives who don't want teenage girls to be able to use contraception or emergency contraception over what Congress has said should be the determination here, which is safety and effectiveness. That was a court stepping in to enforce a democratic decision to give an expert body the major power to decide. And we have seen Congress make multiple decisions to try to ensure that the power of these administrative agencies that are staffed by experts is exercised independently. So some of that is providing tenure protection to people who work within these agencies. By the way, tenure protection that the current administration is trying to run roughshod over in a way that courts have already on multiple occasions said violates the law, although the final chapter of that litigation is yet to be written. Congress has also changed the civil service laws to ensure that people with very significant scientific credentials can get hired by these agencies, without going through the standard civil service process, which is not designed for people with advanced degrees or expertise, and can get paid a lot more than most civil servants can, so that people with significant scientific credentials can be attracted and retained. Congress has provided for various whistleblowing protections for people within scientific agencies, scientific regulatory agencies, so that specifically when they go to Congress and they go to the public and they say that scientific decisions are being subverted by politics or political agendas, they can be protected. So these are all democratic decisions to say we want to elevate certain people with certain backgrounds to make decisions according to certain norms and folkways of particular disciplines. Those are political decisions, but they're political decisions to defer to science. But there's a risk, and this is the last thing I want to talk about before I let my colleagues step in. So there is a way, it is definitely true that when scientific decision makers have made decisions in the United States administrative state, they have done so based on democratic delegations. But they can act in a way that's anti-democratic. So one way they can act as anti-democratic is by pretending that the issues are that their decisions are dictated by scientific analysis when there is a scientific dispute. So I think, some of the ways that people within the public health community have talked about aspects of tobacco regulation or aspects of the COVID response are an example there. Just as the suppression of whistleblowing by scientific decision makers, of scientific decision makers blowing the whistle on political interference undermines the political decision to delegate to scientific decision makers when scientific decision makers themselves hide what considerations they're engaging in and they're considering. That undermines democracy. When they engage paternalistically and say, well, I'm going to tell you what I think you need to know in order to get you to do the thing that I want you to do, but I'm not going to tell you all the reasons why I think it's the right thing to do, that can also undermine democracy. Unfortunately, I think we saw some of that during COVID. Particularly early on when people were talking about masks, saying the evidence of masking was not strong. There remains a dispute about the evidence of masking. But it seems clear that at the time, in the early days of COVID, the reason why, at least in the United States, leading public health officials said there's not strong evidence that masking works was because they wanted to preserve masks for people in healthcare settings. A perfectly good reason that happens to be inconsistent with the idea that masks don't work, by the way. Perfectly good reason, but a reason that was not made public, at least initially, and that undermined the trust that public health officials received later in the pandemic from folks as they were continuing to tell folks to engage in actions that reduce their ability to engage with the world in various ways, including economically. And so one of my calls here is for health officials, scientists, to level with the public, to not engage paternalistically. There's a lot of good evidence that, and I experienced this myself as a person with just the letters JD after my name and not MD or PhD, in dealing with public health officials, there's a lot of evidence that many folks within the scientific public health world just don't believe that the general public can fully understand their reasoning, and so they don't want to engage at the level of what their reasoning is, and that's fundamentally anti-democratic. And so it's important, both for basic democratic reasons and also to secure public trust, which is essential to make scientific regulation work, for scientific regulators to engage in a non-paternalistic way. I think it's also important to bolster other kinds of transparency within our regulatory state. I don't know what your freedom of information regime is within, Canadian government. Ours is relatively weak within the United States government. So the policy that the Food and Drug Administration has when it approves or rejects a tobacco product, for example, is unusual in that the Food and Drug Administration will release to the company all of the underlying disciplinary reviews that went into the decision. So they'll see the chemical analysis, the toxicological analysis, the behavioral science analysis, et cetera. But across the United States executive branch, we have a very strong protection of the so-called deliberative process. So all of the inputs that go into a decision are presumptively protected against public disclosure. This undermines democratic accountability and undermines trust, and it's something that I think we ought to change. Okay, so I could talk for a lot longer, but there are a lot more people who want to talk here. Thank you very much for your patience in listening to me, and I look forward to our discussion.
Well, thank you very much, Sam. I mean, that's fantastic. I wish, we break now just for times for questions, and all of them come from me, but we're not allowed to do that. I should say that there is the chat function for all of you who are watching online, so please put in questions. We will get to questions later. I think Sam raises some really key points when you look at the role that we play when we're doing policy on the broader context of how people see democracy, how are our governments functioning, and the paternalism that he mentioned. Peter Sandman, the now retired professor from Rutgers, who's an expert on risk communications and a wonderful posting on public health tells noble lies, says, people in public health keep asking me, why doesn't the public trust us? And the real question they should be asking, he says, is why aren't we trustworthy? And that gets to the meat of what you were saying, that people feel they're misled. And when we look at what Sam was talking about with vaping and the FDA and regulation of vaping and deciding what products should be allowed, it's in a context of an open market. There are 11 million containers that come into the United States every year. And in recent years, we've seen the rate of decline in cigarette smoking in the United States go from about 2 to 3% per year to now in the range of 8 to 10% per year, and that's because of vaping. But it's not because of the vaping products that were approved by the FDA. Very few people are using those, and Altria, the biggest cigarette company, is saying, we're losing all this to these illicit vapes, things that haven't been approved, but consumers are using them anyway, which is exactly what happened with things like marijuana policy, alcohol prohibition, the Comstock laws that banned contraception. Goldman Sachs had a major report the week before last saying this year, non-combustion products are going to pass cigarettes as the major form of nicotine delivery in the United States, as smokers switch in huge numbers to the alternative products. Largely, almost all of the additional switching is now to products that have not been approved. So that then brings into the question, well, is the science not working, or maybe we just haven't moved into the right sort of science? Is there more knowledge we need to bring in? And how do we catch up? How do we say, if we've done something and it's not working, how do we change our minds? And that's a huge problem that I've lived with all through my career, where you come up with policy that you may think is the best you can do, and then some research comes out saying, well, actually, we sort of messed up. And the view often is, well, we certainly can't tell anybody that. You know, like how many medical officers of health said, you know, closing the parks during COVID, that was a stupid idea. You know, we don't see that. And then that further undermines trust in those authorities. So looking at who else could we be talking to? You know, should we be, say, talking to political scientists? Well, if we're going to be talking to political scientists, we have people like Patrick. Patrick has worked at a senior level in 3 provincial governments in Canada and the federal government. Federal government as the Director General, meaning the brains of the Intergovernmental Affairs Secretariat of the Privy Council, which is the brains of the overall federal government. He then moved into academia, and I totally understand this. When you're immersed in a field and you start looking at it, instead of just doing the work of the field, you start saying, what are we doing here? You know, what's the sociology? What's the politics of what's happening? What can we learn from this? And so he's moved into being faculty, Graduate School of Public International Affairs. He's involved with various other groups, the political science aspect of various issues, but including public health and public health communication. And he is also part of our Center for Health Law Policy and Ethics here. So he's a friend and a colleague, among other things. And I'm looking forward to what he has to tell us.
Thank you, David. I'm delighted to be here today on this panel. I'm very much looking forward to what Sam had to say. But one of the joys of being on this panel is I get to share the stage with Dr. Prativa Baral. Prativa and I have known each other, oh my goodness, a decade before she even started her PhD, because we worked together in something called the Global Strategy Lab, which was initiated here in the law school at the University of Ottawa by Professor Stephen Hoffman, who then went on to York University. One of the sort of core focuses or concerns of the lab is exactly this question of institutional design. How can we organize governments to make good policy, good public health policy, and how can we organize governments to take the science into account? I've been noodling this question for a long time because many years ago, the National Collaborating Center on Healthy Public Policy, which is an agency of the Public Health Agency of Canada, asked me to write a paper, why does the government not do what the evidence says the government should do? Which is a perfectly interesting and logical question from a public health point of view, but from a political science point of view, it is rather an odd question. So I've spent a long time trying to figure this out. So I guess what I want to say is the first part of Sam's remarks, I could not agree with more. It is not helpful to dichotomize politics and evidence for all the reasons he stated. And I would add a couple more, not the least of which, people who make the argument, in so doing, they ignore a whole bunch of research and evidence from philosophy of science, science and technology studies, political science, which shows that it's predicated on the assumption that science and therefore scientific evidence and therefore scientific advice is somehow value neutral. This is sort of taken as a given for many people who are scientists in a classical way, but for people outside who study science from a bit of a distance, these are contestable claims. But I don't have time to get into this here. The thing in the few minutes that I have, I want to zero in on Sam's use of the term scientific regulators and point to some differences between the United States and Canada in this regard. So I've spent the last decade thinking about the question, so who are the regulators in public health in Canada and other parliamentary systems? Unlike the United States, the situation is a bit more complex. Canada and the United States are similar when it comes to product regulation, drugs, safety of food, safety of toys, safety of consumer products. But, and this is critical, whereas the FDA is an autonomous agency, which he described well, decision-making lies with scientific regulators. In Canada, this authority lies with Environment Canada and Health Canada, which are part of the executive. And they don't have the same autonomy. In the end of the day, they behave in very similar ways. And Canadians will all remember when the vaccines became available, we are all waiting, twiddling our thumbs while we were waiting for Health Canada to give the thumbs up that they were safe. This was, at some level, very similar to what happened in the United States. But it's kind of important to note that those people in Health Canada have a relationship with the minister and the cabinet that is very different than in the United States. So my broader point is, in Canada, it's different on food and product regulation, but it's especially different on public health regulation. In Canada, in the United States, the Centers for Disease Control and many state public health actors are styled as and have statutory authority in some cases to be quite independent of the executive. In Canada, we have a much different and arguably weaker regulatory environment. In Canada, there are very few, in fact, no standalone public health regulators. We do have local things that were meant to emulate the CDC. So we have the Public Health Agency of Canada, we have the Public Health Ontario, the Centre for Disease something and something in British Columbia. Can't actually remember its name off the top of my head. And in Quebec, l'Institut National de Santé Publique. If you look quickly, they look a little bit like the CDC. But when you look at it in more detail, they have a quite more complex relationship with the executive branch. And ultimately, as is true in all agencies in parliamentary systems, they are under a great deal of influence and are subservient to the executive. So we don't have that independence. The best example of that, however, are chief medical officers of health. In Canada, they were styled as being sort of semi-autonomous, speaking for the public, acting on the public behalf. But in practice, while they, sometimes by virtue of the way they're appointed, sometimes by the virtue of the independence they have by statute, they are not as independent as we think. So in Canada, the Public Health Act in most provinces basically says the chief medical officer of health can mess with your life. As a political scientist, when I first read the statute, I was shocked. A government official has enormous authority, raises all sorts of interesting questions in terms of democratic accountability. And folks in public health look at that and they say, great, we're going to get a scientifically based action on the part of the government because our guy or our gal, that person who is from our community, has this semi-autonomous role, has all this authority. Well, that's not the way it worked out. Because if you interview them, as I have, you discover that they are very aware that their remit is not simply to be a sort of cipher from the science to the decision maker. Rather, their job is to reconcile many of the things that Sam was talking about. And so part of our challenge in Canada on the public health regulatory side is our institutions are very weak, or at least not variegated enough. So we ask the same person to be the regulator, spokesperson, the advisor, the defender of the public interest, depending on how it's defined. This gets us into all sorts of trouble, as we saw during the pandemic. Different provinces behave different ways. So at minimum, this relationship between science and politics is incredibly harder to discern because of the way we've designed our regulatory institutions. So I'll end on, so where to now? Well, in the United States, there is, and maybe we'll talk about it during the Q&A or later today, Sam alluded to it, people are putting into question the very institutions in the United States that were created and why. We don't have quite the same acute debate now in Canada, but the core question is the same. To what extent do we want to create autonomous decision makers? And so the trend in Canada, in some provinces, we're getting centralization. So the statute is changed and it says, in a public health emergency, cabinet will decide, which on balance is probably not a bad thing. So Alberta is quite explicit in that regard. In other provinces, the debate is going the other direction. So in New Brunswick, there's talk of how can we amend our legislation to make the Chief Medical Officer of Health even more autonomous and independent. And ultimately, I think this kind of misses the point, because at the end of the day, as long as they have all these roles, they are political actors. And so it doesn't help to dichotomize it. We have to accept that as by virtue of being in the executive branch, by virtue of being a senior official, it's their job to reconcile. And that's, maybe it's well designed or not, but that's sort of intrinsic to it. And we as a community, as a public health community, we disagree quite dramatically on how we understand the role. But the bigger question I think we're going to have to struggle with is, what do we do when some of the assumptions underlying all of those designs, both in Canada and the United States, are put into question? There's a whole bunch of people, more in the United States than in Canada, who are asking the question, well, who are these people anyway? And why do they, even if they don't have final authority, why do they have the ear of the politicians? They don't seem to be acting in my interest. And there's a bunch of research that shows that this disquiet about elites, scientists, the managerial class is quite pervasive, more in the United States, but it's true around the world. And while it gets exaggerated, it is a democratic question. Who are these people? On what basis they're providing advice? And in the Q&A, we can get into it. I disagree on the transparency point, at least in a parliamentary system, but that is one of the remedies. If only we knew, if we could, take the cover off and see how decisions were made. It's a bit more complicated in a parliamentary system, but we can talk about that. But we should not underestimate the fundamental challenge to some of those sort of baseline assumptions that we made going back 100 years or more. People are putting them into question, especially in the United States, especially on the radical right. And while they seem exaggerated, at their core, it is a legitimate question about who decides and on what basis. And I submit that in both countries, but for different reasons, our institutions are just not up for the task. Like we can't cope with the challenge. And I'll end on this point. Had we had a proper inquiry post-COVID, provincially or federally, we might maybe have got to these questions. Well, we didn't. So they're kind of still subterranean, but they haven't gone away in the public mind. And the events in the United States suggest they're real. And so we're going to have a bit of a challenge over the next little while. I'll end there.
Thank you very much, Patrick. I think these are really key points. I mean, for those of you who are in the process of becoming lawyers or are looking at doing public policy, we're trying to come up with policies for a reason, right? And in public health, we're trying to do things because we're trying to improve the health, the welfare of the public. If the public doesn't believe you, if the public isn't doing what you want, so as I say on things like vaping, if 17 million Americans switch to products, by and large, products that the government hasn't approved and told them not to use, and they're just ignoring them. Prior to COVID, the Wellcome Trust in the UK, which does this massive global survey about trust in authorities and governments and health agencies, and the question of, how much do you trust government health information? In the United States, 41% of people answered, not even some. And then COVID came. Actually, if you look at the COVID death rates in various countries, it's really closely correlated with how much did they trust the government. If the government says get a vaccination, do they get a vaccination? If they say try to avoid getting together with people and don't French kiss strangers, I mean, are people going to pay attention to that? So I think Hakutani said in her book, Hakutani, the Death of Truth, that once people feel they get better information from an alternative to the authority, and that happens when authorities, people believe those authorities have misled them, it's a very short trip from there to believing all sorts of nonsense from others because you've given up in believing in these authorities. And again, Peter Sandman talks about the same thing, that the causation for people moving to the sort of online nonsense of saying, often these are people who gave up paying attention to an authority because they thought they were being lied to. And then they move into saying, oh, I guess I can believe this guy. So how do we deal with that? How do we deal with the greater problems that Patrick is talking about, the stuff Abraham Maslow talked about in philosophy of science, of scientists being very good at measuring things they know how to measure, equally good at ignoring the things they don't know how to measure. So who do we have in the room that's giving the information that we're measuring? Who do we not have who might be able to give us good insights into what's going on? And this does get into the areas of health communication, health policy, misinformation. And that's an area where Prativa has worked. She's currently with Johns Hopkins, but she has an amazing resume of having advised, as I look at it, the who's who of global public health, and looking at health emergencies, misinformation, and health systems resilience. And I'd now like to call on her to give her views on these issues, and then we will move to questions.
Thank you so much. I'm going to try to take a strategy from folks who fuel misinformation and try to be short and sweet, which is something that academics have a little trouble with, but bear with me. It's really been wonderful to hear the insights from my colleagues and my panelists here. I'm going to be taking on my epi hat and my science communications hat to bring in some of my response to some of what has been said. I'm sure I can speak for an hour just in response to some of this, with regards to the neutrality piece about the distinction between science and politics. As was said by my two co-panelists, that distinction is very much prevalent in a lot of our disciplines. It might be less so in law, perhaps in political science, but in epi and in some of the other disciplines, that is how we view our problems. And so it is a big challenge, I think, ahead of us, even with respect to how we responded to COVID. I also wanted to respond to what was said about the weighing of risks and benefits and how evidence alone is not sufficient to make that weighing, and to ask a question: what happens when that weighing itself is clouded in misinformation? What happens when some of the folks who are doing that weighing are some of the biggest perpetrators of misinformation? How is that scale tipped off in that case? And then the other piece that I also wanted to talk about is, we can talk about science as if it's a static thing when we know that it is not. But a lot of the public, at least the people that we speak to, and a lot of the misinformation and public engagement that I personally have done over the last couple of years, folks see science as a static thing. The scientific process is not something that people easily understand, and particularly when we're dealing with a crisis, something like COVID, when there's an information void and people are latching on to any sort of information that's out there. It's easy to go to what's available, even if that information is false, and to hold on to that, because at the end of the day, they just want to protect their families and their friends and themselves from what's happening. And so, one of the works that I'd done at the very beginning of the pandemic was to reach out to folks and say, where are you getting your information? And it was not from expert authorities, from governments. It was online. It was on social media. And unfortunately, for a lot of us working in the academic spaces, we're not necessarily the most available when it comes to our presence in the social media. So may perhaps in the Q&A discussion piece, we can talk about some of the strategies that we can take to do this. But I'd like to first talk a little bit about some of the examples that we've seen where misinformation has directly led to some decision-making, political decision-making, regulatory decision-making in public health. As we've spoken to at length, it's not evidence that drives decisions, it's politics, it's people, but it's also values. And I think that plays a big role in why and how misinformation is shared and how it's become one of the biggest threats, I would argue, that we will continue to face in the next couple of years, if not more. So how does the dissemination of misinformation in public health affect decision-making? There was some mention of tobacco industry, so I won't go too much into it. But one prime example that I think of outside of COVID is HPV. So the HPV vaccination, when I was in high school, earlier on in my high school grades, it was introduced to girls only, and there was a lot of misinformation that was circulated at that time. And also it was considered an optional thing. You didn't need to go and get vaccinated. Lo and behold, we have longitudinal data today that shows that this is basically a vaccine that prevents cancer. It is one of the most powerful things that we have in public health, and yet there's still so much misinformation that's circulating around that, and that has led to some really real repercussions. So for example, in Japan, the government suspended proactive HPV vaccine promotion, let alone implementation, in 2013. And so coverage dropped from 70% to 1%, and that led to thousands and thousands of preventable cancers. And this recommendation was only reinstated recently in 2022. So thinking about the number of years when we had such an important evidence-based toolkit, but because of misinformation around infertility, about the way that the vaccine was viewed, this decision was made. Similarly, we've seen similar things in Ireland and lots of countries around the world as well. Another example that I think is very, very close to our minds right now is the discussion around vaccines and autism. I'm sure everybody in this room and on Zoom knows that this was based on a redacted paper from years ago that has since then been shown to be absolutely false. And we have many evidence and many studies that indicate that there is no link between the MMR vaccine and autism. And yet there was a recent decision to fund additional studies to potentially investigate that link between the MMR vaccine and autism. So thinking about the money, the resources, the time that will be spent into something like this, when we have ample evidence already that link and that supposed causation does not exist, is another reason that we're seeing this is because of misinformation. I also don't want to get too much into this, but the climate change issue is also a huge one that was fueled by misinformation. And for folks who haven't read the book Merchants of Doubt, it is an excellent book that kind of showcases all of these stakeholders that tend to benefit from this. I think oftentimes, especially folks in public health, and I myself was guilty of this until COVID, think of misinformation as, this thing that happens that's external. It's a couple of keyboard warriors somewhere that are typing things and it spreads, when really it's an orchestrated, it's a multi-million-dollar industry. For people who may not have read the report, there was a Center for Countering Hate in DC released a report in the pandemic called the Disinformation Dozen. And that report showcases that only 12 people were responsible for most of the anti-vax content that was circulating in social media. I think it was 65% of anti-vax content was due to these 12 people. And if you look down the list of these folks, and I won't give them airtime here, they are benefiting financially from this misinformation movement. We're talking about saying, don't listen to them, don't listen to authorities, they are out there to get you, listen to us, and buy my supplements. And so they're benefiting from this. And I think that's something that we are still trying to grapple as to how do we deal with this orchestrated huge movement when a lot of academics are incentivized to just stay within our disciplines and talk amongst ourselves. How do we reach the people that want information but aren't getting it? And the information that's out there is very much misinformation fueled. So the big takeaways here is that, there is false information out there, and what can we do as experts to kind of combat that? And then the second piece is also, misinformation on its own is a huge thing, but then how do we deal with it when, in addition to that, there's the challenge of acting on science in real time? And so one of the last pieces that I'd like to talk about is what can be done. And I'll be very, very brief here. And I think there's multiple levels of response here. And one hat that I'd like to put on is my science comms hat for a second, because I completed an entire PhD, and yet my curriculum did not touch on communicating science to the public. it's just not an incentive to the academic institutions to do that. It's not something that grants us tenure. I'd like to think that that's slowly changing because of COVID, but it's just not something that's in our radar. And I think we're seeing the repercussions of that, because if we're not out there sharing our work in a way that's engaging, that's accessible to the general public, then somebody else without that expertise will do so. And that's kind of what we're seeing with the erosion of trust and whatnot. So there's a couple of suggestions that I might have with regards to how to respond to that. From an academic perspective, being in spaces where we're not comfortable. I'm not asking everybody to be a social media influencer, but I'm saying maybe there are town halls where you can go. Maybe you can partner with community organizations to make sure that the latest evidence is out there. Maybe it's about communicating uncertainty, something that we are very, very, very bad at. Instead of saying, this is what we know, we should perhaps say, and I did a lot of media during COVID, and a lot of the things that I was repeating over and over again is, as of today, based on the data that's available, this is what we know, but this might change tomorrow, and we will update you as that information evolves. So I think really being clear and transparent about that uncertainty is something that we have to do. The misinformation as a field is also an emerging field. And so I think it would be really important for us to monitor misinformation in real time, because these things change fast. And so if we can create some sort of infrastructure to be able to do that, I think would be in a much, much better position. From a public health officials, the communicating uncertainty, really, really liked what Sam said earlier about, the trust in science piece. That's not convincing anyone that can be convinced. And I think there's something there about how do we, and we heard this during COVID a lot, dumbing down the science. And that is something that we should absolutely just reject. We're not dumbing down anything. We're just making information available to the public in a way where their expertise and their lived experiences can understand. So I think changing the framing of how we communicate science is really, really important. And then from a government perspective, I think investing in strategic communications capacity, not just as a reactive thing, but as a preventative thing, is really important. And part of that, I would say, would include funding rapid misinformation response units, because it's too late by the time the information is circulated out there, and we need to be much, much more proactive about that. And then the last piece that I'll say is I think there's something here about citizens and civil society as well. I teach misinformation at Hopkins, and one of the things that we've seen is that there's some phenomenal curriculums out there. So for example, in Finland, kids in kindergarten are introduced to critical thinking. So what that means is that they're able to question information sources. They're able to question when they're being told something, they're skeptical. They're like, where did you get that information? Is that the truth? Was that true yesterday? Is it still true today? And that critical thinking curriculum is introduced at such a young age that it influences the way that they interact with misinformation for the rest of their lives. So I think there's a lot that we can learn here from other countries as well. And I know we only have 10 minutes, so I'll stop here, but happy to talk more during the very small Q&A.
Thanks so much. And the news is apparently we only have 5 minutes. There are just so many things I would like to say, and it's really hard not to do that, but I want to leave time for other people to ask questions. So is there anybody in the room who would like to start with this? Yes.
Thank you. I'm Joachim. I'm LLM. My question is rather related to what Patrick's question was perspective. Who are the people? And then my question is perspective. Who should be the scientists? Should it be lawyers? Should it be policy analysts? Should it be social scientists? What?
Your question is, who should be the people to do what?
Like a minister of health or head of department.
So who should be deciding? Who should be acting? Yeah. And I mean, I think that's a really good question. And I guess, I'll say a couple of things. First of all, I don't think there is some a priori answer to that question. I think it really depends on the political system, the political context, the cultural context. I think one of the issues now, and I want to relate this to the misinformation issue, is certainly in the United States, but I think in the West in general, we are living through this really anti-institutional moment. And it's not just anti-government institutions, it's anti-expert institutions. It is this populist moment. The great book by Wolfgang Streeck called Taking Back Control that kind of articulates what's going on both in Europe and in the United States about this. And it's basically, there is this idea that these expert elite entities of all kinds have taken too much control from ordinary people that is felt by many people. I don't mean to say, normatively I agree or disagree with this, but it is definitely a political moment. And so I think we're going to come to a new settlement of the very question you're asking right now. I mean, in the United States, we're going to have to, because the Trump administration is destroying all of these entities. If the idea is we want to have a Finland-style anti-misinformation education campaign, the Trump administration is dismantling the Department of Education. And one of the reasons they're doing that is to prevent something like this from happening. They're cutting funding to research institutions to prevent institutions like the ones we all work in from being able to do work like this. And I think, some of that is just an overweening response by someone who is going beyond the politics that brought him into office. But there's a real politics there of anti-elitism, anti-institutions, and we're going to have to figure out how we can develop public trust around institutions that are responding to the best information that we know. And I don't know the answer. I mean, so all of which is a good way of saying it is an excellent question. I don't know the answer to.
Very quickly, in a parliamentary system, and given our history, the answer to your question is pretty simple. Who decides ultimately should be those we elect? However, the question then becomes how much autonomy and delegated authority do we wish to give to agencies who regulate on our behalf, knowing that in the parliamentary system, the government can always take back the authority. And so I submit that we have weakly designed institutions now. In the United States, a huge reminder, they don't work very well, so we have to get better. So without falling into the trap of politics versus evidence, careful design is important. But let me end with the following anecdote. 18 months ago, we did a very carefully staged debate at the University of Alberta between people, scientists, and two public health experts. And the final round of questions was, in a crisis, who should decide? The physician and the public health professor were adamant that it should be the experts. And the two political scientists fell off our chairs, rendered unconscious, and when we were getting conscious, we said, wow. So my current preoccupation is no longer why does the government not do what the evidence says the government should do? My current preoccupation is what do we do when we live in a world where people's mistrust, people in public health, mistrust, disdain, lack of understanding of politics is so deep that they actually think that the alternative must be some technocratic response. This is new territory. We've never been here, or at least not in a long time. This is not going to go away. I mean, I'm a political scientist. I find myself defending politicians. I got to say, it's harder and harder as time goes on. But I'm going to stick to doing that for all sorts of reasons. But because here's the thing, and Sam is right, which he is, if we give too much authority back to or to experts, then the problem doesn't go away because they're going to have to deal with politics too. So it's too simple to say one or the other. It's all about the design. And all I'm saying is different countries or different systems need different designs.
Just one point that I'd love to add, it's also the value that we put into expertise and what we consider to be expertise. So when it came to COVID, a lot of the expertise, the lens or the lumière, the light went into epidemiologists, public health officials, when really there was a lot that we could have learned from historians, for example. A lot we could have learned from behavioral scientists in terms of what their response was going to be like to some of the very stringent responses that we took on. And instead we said, oh, this is a virus, so it's going to be virologists, epidemiologists, public health folks who are going to lead the response. And I think that was something that we had to learn the hard way. So to your question, who, to me, it should really be a multidisciplinary team, including leaders of communities, because that's something that we'll have to deal with regards to misinformation.
Great. Oh, thank you very much. We've run out of time, but over lunch, one of the questions that came in, I think is fantastic about what about the declining literacy and numeracy in the USA? And what is that doing to our efforts to combat misinformation? And I'm thinking of the line that 35% of the population has absolutely no idea what 35% of the population means. And numeracy skills have fallen off. I think it's a quarter of people in the OECD do not have basic mathematical reasoning ability. In the United States, it's a third of the population, based on an article in the Financial Times last week. I think it's a huge issue. I think the person who raised the question is great. We can discuss it over lunch. But thanks very much, everybody, coming up.